Hello, everybody. Welcome to my practice inspiration called Small Actions, Big Impact, Game-Changing Patient Strategies for Maintaining Periodontal Health. My name is Dr. Vinay Bhide. I'm a board-certified specialist in periodontics, and I practice in the Greater Toronto area. And it is really an honor for me to have this opportunity to share a couple of pearls with you, which have helped me in my practice, or rather, I should say, help my patients in my practice. And I hope that after seeing this, you'll be inspired to do something similar with your patients as well. Just some relevant disclosures. This practice inspiration is in part sponsored by Procter & Gamble. That being said, I have full creative control over this presentation. I've not been coerced in any way to say anything that I don't agree with, and my presentation certainly will not contain anything investigational or off-label. And everything that I say in my presentation today will be supported by solid, relevant clinical evidence. And last but not least, very, very important for me to say that this inspiration video is in no way meant to be a commercial or an infomercial. I'm really talking about things that I do day to day in my practice, and I may reference some of the products that I use as well. So a little bit about me. I practice in a town called Aurora, which is a small, big city just north of Toronto by about 20 miles or so. And we are the only periodontal practice in town. We are a group periodontal office, and we have an amazing staff. And it's because of these individuals that you see in this picture here that we're able to do what we do that we think at a pretty high level. And I'm blessed to have the opportunity to work with 4 other incredible human beings who also happen to be periodontists, and some of whom happen to be my classmates dating all the way back to dental school. And as this video is called The Practice Inspiration, this is really where I draw inspiration from every single day, is from my own practice and from the individuals that I work with, because we really push each other, we learn from each other, we leverage each other's strengths so that we can all have fantastic patient outcomes, which is really all that we can hope for in our practices, right? So speaking of practice, I took the time very recently to have an idea of what exactly I do in practice, where I spend most of my time on, because people often ask me, how much of your time is spent on implant dentistry, or how much of your time is spent with soft tissue? And I would give them maybe a random answer, which really wasn't that informed until I actually ran the numbers. And I saw that about a third of my time is spent with implant therapy and related procedures. Another third is spent in periodontal plastic surgery. And strikingly, only about 10% of my practice actually is dealing with periodontal disease, whether localized or generalized. Now, this is interesting because it seems like it's a small percentage of what I do, but it's these 10% of patients that actually take up the vast majority of our chair time. Because you think about these patients, they're coming into your office for hygiene and recalls every 3 months for most of their life, really, from the time that they start seeing you. So even though it's 10% on a static basis, when you think of it over the long term, actually probably more than that when you factor in chair time and whatnot. It's also the segment of my practice population that has the most complex treatment needs. Periodontal patients are not prescription surgery patients. You're not just doing a gum graft or crown lengthening. You're treating a chronic inflammatory disease which can never be cured. It can only be controlled, much like diabetes, for example. So these are patients that are with you for life. And this is what a typical stage 3, grade C, or stage 4 patient looks like. We have inflammation, we have attachment loss, recession, plaque and calculus buildup. You can even see that this patient has teeth which are not in alignment, usually the result of pathologic tooth migration. So this is a typical patient that we see in our practice on a daily basis. And treating these patients is not always easy. I mean, this destruction, this deterioration has been in the works for a long, long time. And to reverse this is not an overnight process. When we look at the clinical charting of this patient, all you need to really focus on here are the boxes in red, which represents all the pockets, the probing depths that are 5 millimeters or greater. And then these red dots that you can see here all represent bleeding on probing, which is an indicator of inflammation. So this patient has quite substantial chronic advanced periodontal disease. And periodontal disease really is a I said, chronic inflammatory condition, which is characterized by dysbiotic plaque biofilms, leading to inflammation, and if left untreated, leading to progressive bone loss around teeth, which can then in turn lead to tooth loss, ultimately, if completely left untreated. So before we get into the nuts and bolts of periodontal disease and treatment and whatnot, let's talk about the concept of symbiosis. So symbiosis is really referring to a balance between the host, i.e. the patient, and the oral microbiota. So symbiosis is a mutually beneficial relationship between two entities, in this case the host and the oral microbiota. What happens in periodontal disease is that we lose this balance and we enter the realm of dysbiosis. And this is when there is more pathogenic bacteria in the biofilm than there are good bacteria in the biofilm. And then that interaction with the host over time is altered and you get this great imbalance. And so one of the major challenges of treating perio patients is how do we get that balance back? And in order for us to understand what happens, we have to understand how biofilm forms. Before we talk about plaque, and it's more than just plaque. Biofilm is like an entire village of bacteria, microorganisms, extracellular matrix. It's a community. So it starts with this acquired pellicle, and then over time you get these early colonizers, which then lead to maturation of this biofilm, and then ultimately there's dispersion of the various bacteria in the biofilm back into their planktonic state to start this cycle over again. To give it more detail, we start off with these early colonizers, which are typically the AA complex, green complex, orange associated complex. And then we have the mid colonizers, which are characterized by the orange complex of bacteria. And then we save the worst for last, which are the late colonizers, which are the P. gingivalis, Tannerella forsythia, and then the spirochetes, Treponema denticola. And the analogy that I use is that the early colonizers are like the people that show up a little bit earlier than they should to a house party, right? You're happy that they're there, but they kind of inconvenience you a little bit because you're not quite ready. And then you get more people coming in, and now the volume of people increases. Maybe you're running out of drinks, you're running out of plates or cutlery. And then you get the people that come late, and they're usually the more destructive ones. Maybe they come to the party a little bit inebriated. And so managing these people becomes a bit of a challenge. And so the model for destructive periodontal diseases that we were taught in school was that active disease is a combination of having a compromised host response in the presence of pathogenic bacteria. Now, over time, we've come to realize that it's not just having the presence of pathogenic bacteria with a susceptible host, but also the absence of beneficial species. So what are the goals of periodontal therapy that we talk about when we're seeing our patients? So I'm going to talk about this in broad basis. So, at the very basic level, we're trying to disrupt and remove the plaque and calculus, the existing pathogenic biofilm. And by doing so, we then reduce the numbers of these bad bacteria, or the pathogenic or virulent bacteria. The other thing that we want to do is that we want to also delay how fast these bacteria, the pathogenic ones, recolonize the site. And typically after a good round of scaling and root planing, it can take 2 to 3 months. And this is why we have our perio patients come back every 3 months for hygiene. Over time, what we want to do is to alter the virulence or the pathogenicity of the biofilm. And last but not least, we also want to effect some degree of modulation of the host's immunity so that they can better respond to these pathogenic bacteria. So one of the strategies that I've used in practice over the last few years, particularly for my advanced patients, is the use of probiotics. And by definition, probiotics are live microorganisms that, when administered in adequate amounts, confer a health benefit to the host. Now, the 3 most studied strains when it comes to oral bacteria, oral microbiota, are Lactobacillus, Bifidobacterium, and Saccharomyces. Probiotics are typically categorized or classified according to their genus. An example would be Lactobacillus, which is rod-shaped bacteria. Subclassified further by their species. An example of this would be Reuteri. And then last but not least, and perhaps most important, would be the strain. Example would be DSM 17938. So we have everything put together, Lactobacillus reuteri DSM 17938. And everything really happens at the strain level. It's really the strains that are responsible for the claims that we make about the properties of various probiotics. So they have to be tested at the strain level. And in order for them to be marketed, you have to know what the strain is and what the actual dosage is. So typically listed in colony forming units or CFUs. And there's different probiotic manufacturers on the market, and you just have to look at what strains they are and do your research in terms of whether there's solid evidence to support their use in your patients or not. In the case of lactobacillus, there's a whole variety of evidence, which we'll talk about in a minute or so. As far as mechanism of action is concerned, there's a diversity of mechanisms which drive the beneficial effects of probiotics. But a couple of ones that really stand out to me, I'll talk about. So first of all, we know that there's a three-way communication. It's like a love triangle between the target host, the probiotic, and the colonizing microbiota. One thing that probiotics do very well is immune modulation by increasing the antibody response and in turn decreasing inflammation, and also stimulating the phagocytosis of cells that are unwanted. They also provide what's called colonization resistance, right? It's like once you get rid of the bad bacteria, guess what happens? These probiotic bacteria come in and occupy the space which was once occupied by the bad bacteria. And so it decreases the rate of recolonization of the pathogenic bacteria. So as I mentioned, Lactobacillus reuteri is one of the most abundant probiotics found everywhere in the human body. It varies from individual to individual, but it is the most well-studied and documented. And the probiotics that I use in private practice are a combination of two L. reuteri strains comprising about 200 million colony-forming units. They come in mint lozenge format and very easily tolerated by patients. As far as what the evidence says, the evidence has shown that in patients that are taking probiotics, there's a decreased percentage of sites that typically require surgery. They do slow down the recolonization of the pathogenic bacteria and overall have led to improved clinical outcomes like bleeding on probing pocket depth, clinical attachment levels. And they've also shown to be able to decrease levels of certain deleterious enzymes like matrix metalloproteinase 8, which has been shown to be associated with the degradation of collagen. So very, very important part of my practice, particularly for my advanced perio patients. As far as adverse reactions, very low incidence, except for maybe some GI disturbances. And we do not use these in patients that are immunocompromised because these probiotics already have immune modulating effects. Now, the second strategy which patients use in my practice are very specific type of toothpaste that are good for periodontal patients. Now, there's a whole host of toothpaste out on the market, and I'll highlight which ones I use in private practice. So typically, toothpastes work by either being antimicrobial, they reduce or inhibit plaque, sometimes they inhibit the formation of plaque altogether, and they also have properties to decrease inflammation in the gums or gingivitis. They work either by inhibiting adhesion of bacteria to the tooth surface or subgingivally, preventing the coaggregation of bacteria, disrupting an already existing biofilm, and altering the pathogenicity of the existing biofilm. So stannous fluoride really is a key ingredient in the toothpaste that I recommend for my patients. It's antibacterial. It's also helpful for patients that have sensitivity of exposed roots. And it's really the stannous ion that is responsible for the beneficial actions of this toothpaste. But the big problem is the stability of the stannous fluoride, and typically a stabilizing agent is required, like zinc phosphate, or in the case of a Crest gum detoxify, a citrate gluconate stabilizing agent. The evidence is pretty good in terms of the substantivity. It can penetrate about 2 to 4 millimeters intracellularly and stay there for about 12 hours, leading to decreased bleeding on probing and inflammation. One study showed that after 3 weeks, there was a substantial number of sites that had bleeding on probing in patients that used stannous fluoride toothpaste versus just the sodium fluoride toothpaste. And why is this important? because we know from literature that absence of bleeding on probing is an indicator of periodontal stability. We also know that stannous fluoride causes reductions in PMN cells, which is a key player in inflammation. And they also, just like probiotics, inhibit the release of certain host-mediated enzymes like MMP8. And they cause reductions in the levels of the red complex of bacteria, which is highly beneficial for treating periodontal disease. And a really interesting slide here shows how the stannous actually targets the gram-negative anaerobes found in the red complex of bacteria. You look on the picture on the right side, there's a lot less red bacteria after the use of stannous fluoride toothpaste. So the key messages here are that, we really want to catch patients at the gingivitis stage because this is entirely reversible. But even if a patient has periodontitis, we can actually get them into a state of health, because once a periodontitis patient, they're always perio patient, but we can actually maintain them in a state of health. And some final thoughts and reflections are that, probiotics, stannous fluoride toothpaste provide a good 1-2 punch against pathogenic bacteria and biofilm, and can be a really, really good therapeutic regimen that patients can do at home by themselves, a very good compliance and low cost. And with that being said, I want to thank you all for taking the time to watch this. Please do communicate with me on social media or by email, and I'd be happy to answer any questions that you have. Let's keep the dialogue going. Thank you again, and see you soon.